A very good morning to everyone. I would definitely like to borrow 2 to 3 minutes extra because I've been given the Herculean task of covering three important high-risk situations, planning their delivery. Thanking the organizers for this excellent opportunity. So I'll start with diabetes in pregnancy. How do we plan their delivery? So diabetic pregnancies are a very diverse group. On one extreme, you have a very well-controlled gestational diabetic, no comorbidities, normal fetal growth. And on the other extreme, you have an elderly woman, type 2 diabetic with hypertension, with abnormal fetal growth, particularly LGA. The way in which we plan these two deliveries is going to be very, very different. That brings us to our clinical judgment and individualizing cases. Now, we are all aware of the complications of diabetes in pregnancy, but when it comes to term and we are planning the delivery, the two important concerns that arise in our mind are stillbirth and fetal macrosomia and its consequences. And the common denominator for these two happens to be poor glycemic control. And if you look at both these complications, there is an exponential increase in the risk of these two once we cross 37 and 37 weeks of gestation. This has been studied extensively in research. So do we induce all of them? Is there anything that tells us that subgroup of women amongst these diabetic pregnancies who are at an increased risk of stillbirth and therefore we can take some extra care? Studies have looked at this. People with uncontrolled blood glucose, high BMI, where the fetal weight is less than the 10th or above the 90th centile, and when we go beyond 37 weeks, there is an increased risk of stillbirth. This is a special group. And when we look at macrosomia, again, it is more common in type 1 and type 2 compared to gestational diabetic. Of course, there are exceptions. And here again, glycemic control is a major influencing factor. So when we look at how to plan the delivery, the first and foremost is the glycemic control. So if there is also an end organ dysfunction, say involving eye, kidney, heart, again this is going to play an important role. Her past obstetric history of a stillbirth, previous macrosomia, shoulder dystocia, obstetric sphincter injury will all make an important influence. Her present obstetric factors, whether she has a high BMI, she is elderly, she has preeclampsia and associated growth-related problems, not only large for gestational age, but also small for gestational age, particularly if the diabetes is very, very strictly controlled. Women with a low BMI on very high doses of oral hypoglycemic agents, they are at risk of having a small baby also. Social factors, this was already discussed in the previous talk, whether she can afford coming to the hospital frequently, stay a long time in the hospital for monitoring. Psychological factors, these days they all read the literature, they do Google reviews, and therefore what does she want? What are her fears? Is it acceptable to induce or do expectant management for that particular woman? And also healthcare resources. So the first and foremost on the checklist will be glycemic control, and this should ideally be achieved in a joint clinic because when we are looking at the growth chart, we have a certain perspective and the diabetologist may just be looking at the sugar levels, and therefore we both have to be in the same page. Optimal control of other comorbidities such as hypertension, and do serial scans to make sure we rule out extremes of abnormal growth in the fetus. A maternal cardiac evaluation and anesthetic assessment are very, very crucial, particularly if she's elderly and has a high BMI. Screen for infections such as UTI and involve the pediatricians right from the beginning if the baby has abnormal growth or if the sugars are up and down. When to deliver? Most guidelines would agree that deliver all the diabetic pregnancies at 37 to 39 weeks. If there are any other organ dysfunction or complications, underlying medical problems, it may be planned accordingly. But for some reason, if she decides to wait beyond 38, 39, we have to spend a lot of time counseling and initiate some form of fetal surveillance such as daily fetal movement count or CTG once or twice a week. But we should be aware that these surveillance strategies have their own limitations in predicting stillbirth, and she has to be counseled about that. How to deliver? Per se, diabetes is not an indication for C-section. However, if you have an ultrasound estimation of a very large baby, or she has other obstetric problems in the past or in the present, then it may be prudent to do an elective C-section. When we plan delivery, ideally it should be in the daytime with the involvement of all the members of the multidisciplinary team, the senior obstetricians, diabetologist, physician, anesthesiologist, and anesthetist should be involved if she is elderly, and we should have got a pre-anesthetic assessment. And be aware of diabetic ketoacidosis even with euglycemia, and here diabetologist involvement is very, very important. Every unit should have a protocol for intrapartum glycemic blood sugar management. Some people use intermittent boluses, some units use subcutaneous, continuous subcutaneous pumps. Whatever the method may be aware of hypoglycemia and be ready with 20% dextrose solution. And try to achieve an intrapartum glucose level of 70 to 120, maybe 140 if it's an operative delivery. And for intrapartum pain relief, neuraxial anesthesia, combined spinal epidural or epidural is safe. Again, beware of hypotension once we initiate epidural analgesia, and be ready with crystalloid solutions. Here again, anesthetist involvement is very, very important. We'll just run through a few cases. A type 1 diabetic, very well controlled, normal fetal growth, 36 weeks she shows an estimated fetal weight of 9th centile. Again, there is no need to rush and do a C-section. We can counsel her for induction at 38 weeks. If she wants to wait, that may not be a sensible option because the growth parameters are already beginning to drop. The second scenario is type 2 diabetic on insulin and OHA, poorly controlled with an estimated fetal weight above the 95th centile. Again, there is a high risk of stillbirth, and therefore we need to deliver her early. So the third scenario, somebody on who conceived with IVF type 2 diabetic on labetalol and with growth restriction. Again, here hypertension growth parameters are growth abnormality is an additional risk factor, and we may have to base our delivery depending on these factors. Somebody with polyhydramnios in threatened preterm labor, we all know that steroids are indicated in her, and this is going to worsen her sugar. Therefore, keep her in the hospital even if she doesn't go on to deliver, and control her sugar appropriately. Finally, a gestational diabetic, very well controlled, wants to know if she can wait beyond 41 weeks. Generally, in our practice, most of us would try and deliver her by 40, but if all is well, most guidelines say we can wait up to 40 plus 6 weeks. Now I'll go on to hypertension in pregnancy, which has many phases, as you're all aware, starting from pre-gestational hypertension, gestational hypertension, to preeclampsia when there is proteinuria, organ dysfunction, hepatic dysfunction, and hematological abnormalities. And you can have a combination of pre-gestational hypertension with superimposed preeclampsia. Now, as you go from one to the other, the maternal and perinatal morbidity increases. Again, severity of hypertension will be the most important factor which will help us to decide delivery. Her underlying problems of other medical comorbidities also will play a role, and her obstetric factors and our NICU care. As we are planning, probably three patterns will evolve in our mind. One is when there is very, very well-controlled hypertension with normal fetal growth, we would like to take her up to 38 weeks. Whereas when the hypertension is unstable, she's on multiple medications with proteinuria, early fetal growth, we are not looking at immediate delivery, probably in 2 to 3 weeks. This is an important area because this needs continuous monitoring, because she may cross over from a medium or moderate level to an urgent level where there will be severe preeclampsia, uncontrolled hypertension, HELP syndrome, eclampsia, and severe growth restriction, where immediate delivery will have to be done. ACOG recommends deliver all hypertensive pregnancies at 37 weeks, whereas some other guidelines would say if other than well-controlled hypertension, no other comorbidities or problems, you can wait up to 38 weeks. Now, optimal control of hypertension with labetalol being the first line drug and nifedipine is added as the second line in case we need to go beyond 1.2 grams of labetalol in a day. A maternal cardiac evaluation and echo are mandatory in all pregnancies. And most of them will be on echosprin, and it is wise to stop 1 week before if you are planning delivery. However, in case she has to be delivered immediately, it does not increase the risk of bleeding. And when we are planning a preterm delivery for some reason, maternal or fetal condition, then we have to time the steroids accordingly. Plan the delivery during the daytime involving all the members of the multidisciplinary team. Get a fresh set of investigations, particularly platelet count and coagulation profile. Elective cesarean is probably sensible if the blood pressure is very high and uncontrolled. We can't wait for induction. However, control the hypertension well before we induce general anesthesia and spinal regional anesthesia, rule out all the contraindications because there can be sudden surge during induction and that can lead to cerebrovascular accidents. And magnesium sulfate may be indicated for neuroprotection and it should be run for at least 4 hours before the planned delivery. It may also help to prevent eclampsia. Induction is safe if the hypertension is well controlled and if the Bishop's score is favorable. Epidural is safe. And we have multiple infusions running, starting from oxytocin and antihypertensive and magnesium sulfate. Please make sure all the people in the labor room are aware of what is going on. And be familiar with the protocol of management of acute and severe hypertension. Keep the eclampsia tray ready, and regular drills should be done in order that everybody is aware of what to do sequentially. So going through a few hypertension cases, somebody with pre-gestational hypertension, very well controlled, induction is safe at 39 weeks. The same woman has preeclampsia, well controlled again on labetalol. Here we would view her with little bit more seriousness, closely monitoring her because anytime she can go, the hypertension can escalate. The third scenario where there is twin pregnancy on hypertensive on labetalol with a 2+ of protein. Here it is a little bit more serious where you would admit and monitor her more closely, get a growth scan, plan steroids because delivery may have to be planned in 1 to 2 weeks. And the second scenario where there is an underlying SLE where there is a lupus flare, again, delivery may not be immediately necessary. We can control the flare with escalating the dose of steroids, and if she responds, we can delay the delivery. And the fifth scenario, somebody on labetalol develops vomiting and on investigation has deranged liver function and low platelets. Again, HELP syndrome can be a life-threatening emergency where delivery has to be planned immediately after correcting her coagulation parameters and platelets. And somebody who has been well managed goes on to having a PPH post-term. Remember, eclampsia, in pre-eclampsia, there is constriction of intravascular volume and they tolerate blood loss very, very poorly, and therefore fluid management has to be done by a multidisciplinary team in the ICU or HDU. We'll go on to fetal growth restriction. For the sake of postgraduates, I thought I'll state a few fundamental facts. To manage growth restriction, accurate assessment of gestational age and EDD is fundamental. And once you do this with the early scans, do not change the gestational age or the EDD. You only look at the change in the centiles of the growth parameters. We basically measure BPD, AC, HC, and FL and plot them on standard charts. One moment, let me. Why do we plot them on charts? This is because if we mark the measurement on the chart, it gives the growth at that particular point. If you see these charts, they have a lower range, a critical cutoff of 5th centile, sometimes 10th centile, and an upper cutoff of 90th or 95th centile. If we make another subsequent measurement and connect these two dots, what we call as interval growth is something that will come up. And this is very important to differentiate a normal and an abnormal growth, because a growth restricted baby will have will have a drop in the growth centile as opposed to a normally growing baby, which will maintain its growth centile. And we also do a Doppler study on the uterine artery, umbilical artery, which reflects the placental vascular resistance, and a fetal middle cerebral artery and ductus venosus. A significant high resistance flow is indicated by a PI of more than 95th centile. And when we say increased flow in MCA, cerebral redistribution, we mean a PI less than the 5th centile. The first question we should be asking is the growth restriction pathological or is it a constitutionally small baby? So when we have AC or EFW less than the 10th centile, it is a SGA baby. If the growth is between 3rd and 10th with a normal Doppler, it is a constitutionally small baby. If it is less than the 3rd or between the 3rd and 10th with abnormal Doppler, it is a pathologically growth restricted fetus. Now in many papers, SGA and constitutionally small babies are terms that are interchangeably used. You should be aware of that. So what is the difference between these two and why should we know the distinction? It is because a constitutionally small baby will start at a lower centile but will continue to grow in the same centile, whereas a pathologically growth restricted baby, there will be a drop in the centile. And the second question, if there is FGR, is it early or late? A gestational age of 32 weeks distinguishes these two. Late FGR, there is challenge in diagnosis because weight estimation, fetal weight estimation can be erroneous in the late trimester. And being a mature fetus, it tolerates the hypoxia poorly, and it is a very common cause of stillbirth at term. And to manage FGR, we should know there are a sequence of events. So stage 1 is when the umbilical artery PA is above the 95th centile. Stage 2 is when there is absence. Stage 3 when there is reversal of end diastolic flow. Stage 4 is when there are ductus venosus changes. In late FGR, this final deterioration where there is from fetal hypoxia, it goes on to fetal acidemia and fetal death if left undelivered. That can happen within a matter of few hours. And this pattern or sequence may be very unpredictable when there is an underlying maternal disease such as preeclampsia. So when do we deliver? To answer this question, usually 2 studies are quoted. One is the growth restriction intervention study or the GRID study, which looked at FGR between 24 and 36 weeks. Here, they looked at immediate delivery versus delaying until there is no uncertainty. What they found was when the delivery was done immediately, the disability was more. That brings us to the important concept that prematurity or the gestational age is probably the most important determinant of how the babies do beyond delivery. The second study was Truffle, which looked at only early onset FGR. And here they base their delivery based on 3 arms. One is ductus venosus PI more than 95th centile, or ductus venosus absence of delayed A wave. And arm 3 was reduction in short-term variability in computerized CTG. This is different from the CTG that we commonly use in our practice. Explaining the results in a simple way, if the FGR is less than 30 weeks, do not rush and deliver based on abnormal umbilical artery changes. Wait as long as the ductus venosus changes are normal, because these babies do well if delivered, if they wait until changes in ductus venosus happens. If the baby goes beyond 30 weeks, then you can base your delivery based on umbilical artery changes. In stage 1, monitor them weekly and take them up to 37 weeks. In stage 2, monitor them bi-weekly and plan delivery at about 32 weeks. Stage 3, when there is reversal of flow, we have to monitor them more closely every 1 to 2 days and deliver them at 30 weeks. If there are ductus venosus changes, that is stage 4, wait only as long as viability is reached, that is 26 to 28 weeks. And again, in the stage 1 alone, we can probably plan induction by a mechanical method. In all the other stages, cesarean section is indicated. In late onset IUGR, there are challenges. in order that we don't miss the late onset IUGR in low-risk pregnancies, when we do a third trimester scan, it may be sensible to do them as late as 36 weeks. Here, the estimated fetal weight may still be above the 10 centile, but there may be a significant drop of more than 2 quartile, that is 50 centiles, and that may be abnormal finding. MCA, again, may be normal, but here we introduce another term, cerebroplacental redistribution, which is a ratio of umbilical and MCA-PI, and if it is less than 1, that is abnormal. There is no uniform consensus as to how to monitor them, but generally we do biometry every 2 weeks and a Doppler every week, and if there is a significant drop and CPR falls to less than 1, plan the delivery. Finally, constitutionally small babies have a normal perinatal outcome. Should we monitor them at all? Yes, we should, because only by monitoring we know they are growing according to their growth potential. So biometry every 2 weeks is indicated in this group, and to make sure they don't cross over to pathological growth restriction. And therefore, if there are no comorbidities, if the centiles are above the third, and if there is no significant drop, and if the Dopplers are all normal, we can take them up to 40 weeks. However, each case has to be individualized, and then plan early delivery has to be planned. So I think I've come to the last slide. Thanks for the extra time. I'll be happy to take questions at the end of the session. Thank you.
Thank you. Thank you so much, ma'am.